The primary and most important question is precisely how long postoperative swelling should realistically last. So today I'm going to explain to you the 10 main causes of postoperative swelling and what is normal and what isn't during this recovery period. I decided to bring you the 10 main causes of swelling after blepharoplasty surgery. So if you're out there thinking about having eyelid surgery or a facelift, or if you've already had one and are in the early post-op period and are unsure whether what you're experiencing is normal or not, stay with me because I'm going to explain it to you. The first cause of post-operative swelling, injectables. In my daily practice here at the clinic, the first cause is injectables, the second cause is injectables, the third cause is injectables. By the 10th cause, I might think of something else, but by far, the main cause of prolonged swelling after surgery is injectables. Prolonged swelling is that which lasts more than 30 or 40 days. A little swelling, that slight puffiness, is normal. It comes and goes. What isn't normal is for the patient to have a very swollen eye after surgery, even after 30 or 40 days. That's not normal. And here the main cause is injectables. And usually when we have that doubt, we request a dermatological ultrasound. As a routine here at the clinic, I order this exam preoperatively for everyone with a history of injectables: biostimulator, harmonica, hyaluronic acid, Restylane, Radiesse. When a patient has a history of having had a product injected in the face, I request a dermatological ultrasound. And when we find product in this area, the face, temple region, cheekbone area, zygomatic region, eyelid area, I ask my dermatologist to remove the product. And here we always perform ultrasound-guided procedures to ensure maximum precision and accuracy in removing this product. So this, let's say, would be the gold standard approach for everyone who is considering facial surgery. And even with all this care, I have already had patients. In fact, I currently have a post-operative patient who developed swelling in the lower eyelid and she had no history of injectables. And I told her when she came back 2 days after surgery to have the hemostatic mesh removed, I said, look, this swelling in your lower eyelid, until proven otherwise, is due to injectables. And then I always get that classic response from my patients: doctor, but I've never had any product injected in that area. You may not have had it done, but someone did it for you. And it's amazing how most people don't know what's in their face, what was injected. Some simply forget because it's been years since they had the procedure. And others really don't know because when you have the procedure done and you're lying there with your eyes closed and someone is using a cannula on your face, you don't see what's being injected or where it's being injected. You just feel that something is being done. Something is being done. So the most prudent thing in these cases, if you've ever had any injectable that isn't Botox with a little needle in your face, is to get a dermatological ultrasound before surgery. I also have a case of one of my patients who went in for surgery just on her neck. She was going to have an isolated neck lift and she had a history of having had a biostimulator injected both along the jawline and in the midface. And she had those nodules from the biostimulator. So this patient, instead of doing a full facial screening, only had the removal done in the Jones area. And in the post-operative period of the neck lift surgery, the product she had in her eyelid was reactivated. So this patient taught me that even when you have a surgery localized to one area, if the patient has filler in a critical zone, it has to be removed because otherwise you reactivate the product and then the patient ends up spending 3 or 4 months with that swelling, which has nothing to do with the surgery or the procedure that was performed. So here's my advice for everyone. If you have a history of injectables in your face, get an exam before having surgery to avoid a future headache. Because then it's double the work. One to deal with the swelling, another to do the exam, and another to remove the P product. So let's save everyone the trouble and do the exam beforehand. And whatever needs to be removed should be removed before the procedure. Here's my tip, my public service announcement. Well, so you had your dermatological ultrasound done very thoroughly with a good specialist and you have no fillers in your face. Great, and even so you still have swelling. What should you consider? It could be a genetic cause, right? There are patients who have a genetic tendency to develop facial swelling. I have several patients here who complain about this. They say that every time they sleep poorly, which is another cause of swelling, right? So the third cause of swelling, besides genetics, is poor sleep. The fourth is diet. There are people who really, when they drink alcohol, when they eat very salty food with excess sodium, they get more swollen the next day. Usually this swelling can't be controlled. This type of patient tends to swell more after surgery, to stay swollen for a longer period, but they don't stay swollen for 3 or 4 months. They stay a bit more swollen during that standard period. By the end of the first month, there's still a slight residual swelling, but we can tell it's normal swelling. When it's abnormal, the surgeon notices that it has deviated from the pattern we usually consider normal. So these changes that are genetic, dietary, or due to sleep disturbances, they really do worsen the swelling, but it's more, in quotes, normal. Another important cause. Now let's talk about diseases. Hypothyroidism, which is a very common disease in women over 40, especially Hashimoto's disease, which is an autoimmune disorder. It really does increase swelling, but it's a kind of generalized swelling. The patient becomes more swollen. She tends to retain more water. This is normal. Usually, in these cases, if the patient's thyroid is well controlled, it's just a matter of time before the swelling improves. On very rare occasions, when the patient has facial edema, I prescribe a mild diuretic like aldactone or something similar, a potassium-sparing one. But that's very rare. Usually it goes away on its own. You don't need to do much. Another condition we have to consider is kidney failure, and another is decompensated heart failure. Now, if we stop to think that we're operating on an aesthetic patient, these are patients who shouldn't even have been operated on in the first place. So I have a patient right now who is in the preoperative stage. She's a chronic kidney patient. She undergoes dialysis and she wants to have eyelid surgery. She wants to have facial surgery. With this type of patient, we have to be extra careful in the preoperative preparation. Minor surgeries. So I've already told her it has to be a small procedure, nothing too aggressive. We need to be in close contact with her nephrologist, with her cardiologist, make sure everything is perfectly organized, all the electrolytes are balanced, avoid excess sodium, adjust some medications, avoid excess sodium. So there's a whole plan behind treating this group of special patients. Another issue here, which isn't exactly a disease but can happen, is allergic reactions. Sometimes it happens that the patient has an allergic reaction to medication. Today I saw a patient who is a doctor and she said she had an allergic reaction to propofol. Propofol is a sedative that we use in almost all sedations, general anesthesia, endoscopies, and so on. It's an extremely widely used medication. And this patient, who is a doctor, said, I had a reaction to propofol and my eye got really swollen and I had trouble seeing. After the effect of the medication wore off, everything went back to normal, but it just goes to show that even the medications we consider the most harmless can cause allergic reactions in people. Infections, right? Localized infectious processes. Then there are blepharitis cases, which are styes that can happen after surgery. They're more common in patients who have rosacea, that oilier skin type. So we have to keep an eye out for blepharitis. And conjunctivitis itself, sometimes a medicamentous conjunctivitis, which is the most common. We use eye drops, we use antibiotic ointment, and so on. Sometimes the patient doesn't store the product properly at home and they can end up with conjunctivitis, either allergic or even bacterial. Then we have to treat the cause, right? Which would be these localized infections. By addressing all these causes, if we manage to control all of them, the patient's swelling will be related to one of them. So every time I see a patient of mine or someone who comes to me for another reason but has this complaint, I try to fit them into one of these causes. And then I rule them out one by one. And as you may have noticed, the first cause I always look for is injectable, which is the presence of product residue. I think that this kind of clinical reasoning is something that most of you don't know about, that this is how we think. This is how we rule out diagnoses. But it's interesting for you to know, even for when you consider having surgery or advising someone else, this will help you gain this kind of understanding about how medicine works, okay? Have a great week, everyone. Bye.